Bismillahirrahmanirrahim. Hello and welcome back. In this video, we will discuss the 8th code in our 12 codes for ECG interpretation, which is a large and very important one, QRS complex. As you know, QRS complex represents ventricular depolarization. And as a ventricle has a large muscle mass, so the QRS amplitude will be larger than the P wave amplitude, which represents atrial depolarization. So the normal parameters for QRS complex, it should have a duration or width of the QRS complex less than 120 millisecond, about 3 small squares. This is its width, and its amplitude or size of the QRS complex less than 3 large squares. I mean, as we have mentioned before, 1 large square equals 0.5 millivolt, so it should be less than 1.5 millivolt. So the normal QRS complex is, the key here is 3. Its duration or width less than 3 small squares, and its amplitude or height less than 3 large squares. Okay. QRS complex is formed of 3 parts: Q, R, and S waves. In order to identify these parts very easily, please follow the following concept. The QRS follows the P wave. The first negative wave following the P wave is the Q wave. And the next positive wave, or the first positive wave following the P wave, is the R wave. And the second negative wave after a positive one is the S wave. So Q wave is the first negative wave after B wave, or is the first positive wave, and S is a negative wave after a positive wave. For your knowledge, QRS complex not necessarily in all leads formed of the 3 parts of the wave. Sometimes there is no Q and only RS. Sometimes there is no S and only QR, and sometimes it is an RS. So not the always one which is present is the R wave, but sometimes Q wave not present or S wave not present. If you look here, this the QRS is formed only by a negative wave, so this wave is called Q wave. Neglect the S. If you look here, the B wave followed by, this is a positive deflection, so this is the R, and the negative deflection before R is S, so this is an RS wave. Here, the first negative wave is the Q, and the first positive one is R, so here it is QR wave. Here, the first positive wave should be an R. Then the next negative one is S. And here there is another R, and this is called RS, R prime. Here there are 2 R waves, and this pattern is pathognomonic for right bundle branch block, as we will discuss later. Okay. From which, or what is the electrical basis for developing of Q, R, and S? As you know, the QRS complex represents electrical impulse passing through the ventricle. It is larger in amplitude than B wave due to larger muscle mass of the ventricle. Following always QRS follows the B wave and made of a Q wave, R wave, and S wave. If you look here, for example, for the lead 5, which is one of the leads that contains the Q, R, and S. So we can understand these waves from here. The start of ventricular depolarization occurs in the septum, and septum depolarizes from left side to the right side. So its direction of depolarization is like this. So it is towards the V1 produce, and when electricity go towards the lead, it produces a positive wave, as we have mentioned before. And when it goes away from another lead, it will produce a negative one. So here it is directed towards the V1, so produces a positive wave, which is an R wave. and it goes away from lead 5, so it produces a negative wave, which is a small Q wave. Then depolarization of the ventricle occur, producing the second wave. Here it goes away from the lead one, so it produces a negative wave, which is a large S, but it goes towards the V5, so it produces a large wave, which is the R wave. And finally, depolarization goes up, produces the next negative wave, which is the S wave. So here, the first part of the QRS is formed by depolarization of the septum, and the other parts of QRS formed by depolarization of rest of the ventricle. Okay, so Q wave is the first negative deflection following the B wave. It represents the polarization of interventricular septum from left to the right. The R wave is the first upright waveform following the B wave and represents the ventricular depolarization. And S wave is a negative waveform following the R wave. And for your knowledge, not all QRS complexes have Q, R, and S waves, not all of them. Okay, so after knowing the normal morphology, shape, amplitude, and the duration of the QRS complex, what are the QRS abnormalities? There are four major abnormalities that can we detect from the QRS. The first one is what we call R wave progression. We will discuss it soon. The second one is presence of pathological Q waves. And when we say pathological Q waves, this means that there is a physiological one. And the next abnormalities is a change in the shape of the QRS complex due to presence of a bundle branch block. And finally, a change in the amplitude of the QRS complex due to increase in the muscle mass, or what we call ventricular hypertrophy, either left ventricular hypertrophy or right ventricular hypertrophy. All these pathologies will be discussed soon during this video. The first one is the normal R wave progression. Normally, there is a progression of the R wave in the precordial leads from V1 going through to V6. As we have mentioned that V1, which is directed towards the septum, electricity at first produces, towards it, so produces small r. Then main electrical activity of the ventricle go away from it, producing a deep S. So normally in V1, there is an initial small r followed by a deep S. And as we go through away from the septum towards the left side, the R wave increase and the S wave decrease. This is the situation in V2. And in V3, both are equal, or what we call biphasic. The R and S equal each other. Then from V5 to V6, the R wave become larger or bigger than the S wave. And this is the normal pattern or the normal R wave progression. If you look at this ECG, this is the V1, there is a tall R and small S, then S become more deeper, then R become more pronounced with a smaller S, and this is the normal R wave progression. If you look here, this is a tall R, smaller S, more enlargement of the R wave. Here it should be more biphasic, and here mainly R and small S. What about this ECG? If you look here, there is very small R with deep S, also deep S, no biphasic waves, also deep S, no tall R. Here, start of the R wave, and this is called the poor R progression, and this is very characteristic for heart failure with reduced ejection fraction due to ventricular dilatation and impairment of systolic function. This is the most common pathology that produce poor R progression. Here in V3, there should be a biphasic wave. R equal S, but here it's only S wave, so this is a poor R progression. The second pathology is the pathological Q waves. And as I have mentioned, when we say pathological Q waves, this means that there is a physiological Q. Yes, in some leads, like inferior leads, lead to 3 and AVF, like V5 and 6, there is a small initial Q waves, what we call physiological Q waves. So what are the characteristics of the pathological Q? And for simplification, we say it 2.1. So pathological Q should be at least 2 small squares in its amplitude and at least 1 square in its duration. So 2 by 1, at least 2 squares in its amplitude and at least 1 square in its duration. Here in this ECG, you can see a pathological Q followed by an R. And here you can see that the QRS complex is formed only of a pathological Q with deeper amplitude 1, 2, 3, 4, 5 and a half in the amplitude, and in the duration about 1.5 also in its duration. So these are a pathological Q, and pathological Q denoting a neglected myocardial infarction or past myocardial infarction, that this part of the heart is infarcted totally and enough time passed over this infarction. So it denotes a past myocardial infarction. Then we will come to a change which pathology which changes the morphology or the shape of the QRS complex, which is bundle branch block. And as you know, that we have a right bundle, we have a left bundle that divides into left anterior fascicle and left posterior fascicle. All of these branches can be blocked. So we have a right bundle branch block, we have a left bundle, we have a left anterior fascicular block and left posterior fascicular block. Each of these bundle branch blocks will produce a characteristic shape in the QRS complex morphology that we should have and memorize by heart. And I promise you it will be very easy soon. All of these bundle branch blocks can be, we call it complete or incomplete according to its duration. If the duration is larger than 3 small squares, which equals 120 milliseconds, so it is complete bundle branch block. If it is smaller than 3 squares in its duration, I mean less than 120 milliseconds, so it is incomplete, as we will see sooner. The right bundle branch block. In order to define the bundle branch block is a right bundle or left bundle, you should look at 2 leads, V1 and lead 1. V1 and lead 1. When you find an M-shaped QRS complex with RSR prime pattern in V1, so it is the right bundle. And also you'll find a slurred S in lead 1. But as you see in this ECG, in V1, there is an M-shaped QRS complex RSR prime. And when you look at lead 1 to confirm, you'll find a slurred S. Curved S. So this is the right bundle branch block. But in left bundle branch block, you'll find an M-shaped QRS in lead 1. So in right bundle, you'll find the M shape in V1, while in left bundle, you'll find the M shape in lead 1, like this ECG. In lead 1, you'll find the RSR R prime, the M-shaped QRS complex. This denotes left bundle branch block. And when you look at V1, you will find a deep Q with ST segment elevation, and this confirms presence of left bundle branch block. So the right bundle, the M shape is in the V1, but in the left bundle, the M shape is in lead 1, as we have mentioned. Okay. Then we come to the left anterior fascicular block, and this is very easy. Left anterior fascicular block characterized by presence of deep S in inferior leads. It leads 2, 3, and AVF. As you look here, there is a deep S in lead 2, 3, and AVF, and this is called left anterior fascicular block. Left anterior fascicular block, presence of negative waves in inferior leads 2, 3, and AVF. But if you find negative waves in 1 and AVL leads, in lateral lead 1 and AVL, like this is a deep S in 1 and the AVL in lateral leads. This denotes the presence of left posterior fascicular block. So when you find the negative wave, or deep S in inferior leads 2, 3, and AVF leads, this is a left anterior fascicular block. But if you find the deep S in lead 1 and AVL, this is left posterior fascicular block. Unfortunately, this pattern should be memorized always, and after many practices, you'll find it very easy. Here you can find a 2 bundle branch block, what we call bifascicular block. And bifascicular block, the commonest form is presence of a right bundle branch block. Here you can see an RSR dash M shape MV1. So this is a right bundle, but also you can find a deep S in inferior leads 2, 3, and AVF. So left anterior fascicle. And this is very common association to find a right bundle branch block with left anterior fascicular block, what we call a bifascicular block. And this is very common to find it, a bifascicular block, presence of right bundle branch block with left anterior fascicular block. Okay, then we'll go through the pathology that changes the amplitude and makes the QRS complex more wider, which is ventricular hypertrophy. The first one is left ventricular hypertrophy, and the second one is right ventricular hypertrophy. And in order to make it very easy, let's go to the whiteboard. This is the heart. This is the right ventricle. And this is the left ventricle. When the muscle of the left ventricle become hypertrophied, like this, its electricity will increase. So this is the electrical direction of left ventricular hypertrophy. So it will produce a deeper S in these electrodes in V1 and V2, which is away from it, and will produce a larger R in V5 and V6, where the electricity goes toward it. Okay, so the characteristics of left ventricular hypertrophy, or what we call LVH, is presence of a deep S in V1 and V2, and tall R in V5 and V6. And there is a criteria for this. If the deepest S in V1 and V2 more than 5 square, large square, or the tall R is more than 5 squares. This is characteristic. Or if the tallest R plus deepest S more than 7 large squares. These are what we call school criteria for left ventricular hypertrophy. When you find a deep S above 5 large squares, or a tall R above 5 large square, or the sum of the tallest S plus deepest R above 7 large squares. So this denotes the presence of left ventricular hypertrophy. Let's go to ECG and see it. Yes, here, if you look, this is V2, whereas there is a deep S wave. Here is S1, 2, 3, and 4. So it is not equal to 5. But here, when you look at V5, it's 1, 2, 3, 4, 5, 6, and 7. It's about 7 squares. So this is basognomonic for presence of left ventricular hypertrophy. So the deepest S plus tallest R should be above 7 squares, large square. And differential diagnosis of left ventricular hypertrophy, either hypertension or aortic stenosis, hypertrophic cardiomyopathy, presence of aortic coarctation, or a Sleep's heart, which causes hypertrophy of the ventricle. But left ventricular hypertrophy criteria in ECG may be false positive. I mean, presence of the criteria with normal ventricle, no hypertrophy. This is found in thin chest wall in thin people due to the nearer heart towards the chest wall, causing the electrical voltage to be higher, or maybe due to incorrect standardization and imaging the ECG at a double calibration, as we have mentioned before, producing these criteria. This is the differential diagnosis. Okay, if you look here, there is MV1 and MV2 very deep S, 1, 2, 3, 4, 5, 6, about 6 squares. This is basognomonic. If you look at the tallest R, you will find it above 5 squares. If you sum both of them, you will find them above 7 large squares. So this is basognomonic of left ventricular hypertrophy. What about right ventricular hypertrophy? Let's go to the whiteboard. What about when the right ventricle become hypertrophied? Like this. Like this. Yes, here the electrical axis will be directed to the right. So in the right leads in V1 and V2, you will find a very large R wave like this. You'll find the R wave will be very large in V1 and V2. And you will find the R wave in V5 and V6 will be very small. Like this. So in right ventricular hypertrophy, it's basognomonic to find a very tall R in V1 and V2. Okay, let's see it. So you'll find a tall R in V1 and V2. And in any ventricular hypertrophy, you'll find a strain. As you know, when ventricular hypertrophy occurs, it causes amplification of the depolarization and also amplification of repolarization, affecting the ST segment, causing what we call strain. There is an left ventricular hypertrophy strain and right ventricular hypertrophy strain. And this part will be discussed when we discuss the T wave and ST segment. Also, from the criteria of right ventricular hypertrophy, you will find a tall R in AVR due to its near position to the right ventricle, and also you'll find a left posterior fascicular block. Do you remember it? I mean, you'll find a deep S in lead 1 and the AVL. Let's see it. When you look, you'll find a very tall R in V1 and V2. You will find an inverted T with ST depression in V1, V2, and V3, and this is called RV strain. You will find a tall R in AVR, and you will find a deep S in 1 and AVL, or what we call left posterior fascicular block. So the 4 criteria for right ventricular hypertrophy are present. Presence of tall R in V1, V2, V3, and V4, presence of RV strain in the form of inverted T and ST depression in V1, V2, and V3. You'll find a tall R in AVR, and you find here a left posterior fascicular block DBS in lead 1 and AVL. So these four criteria are characteristic for right ventricular hypertrophy, and the most common causes of right ventricular hypertrophy is chronic obstructive pulmonary disease, COPD, due to pulmonary hypertension, but also pulmonary embolism, tricuspid regurg, presence of atrial septal defect. All these situations cause pressure and volume overload on the right ventricle, causing right ventricle to hypertrophy, producing this pattern. I know that QRS complex morphology, shape, and duration are very difficult. I hope that you know the normal first and then identify the 5 different pathologies that can we diagnose from QRS morphology. Thank you very much, and see you in the next video with another code of our 12 codes. Goodbye.